Read the EKG.
강원호 선생님 유튜브에 박제됩니다. At first, on VO read, it is positive, and on VF read, it is positive, so the axis is not deviating, and the heart rate is about. And first, it is not regular, and the heart rate is about 130 to 150, and okay, 민정?
There is 3 different group of SVT.
Speak louder, please.
I think it is sinus with the ATC.
Which lead?
That's the lead to. At the first 7 bit.
마우스로 좀 따라올래요?
Sinus because the first reading T wave, and there is some ATC, and after that will be this one is T wave with the comparing with the previous 7 bits, it is the PR interval is quite prolonged. After that, there was the neo-PR tachycardia with the retrograde P wave after the Q PR contrast.
Where is the retrograde P wave? Sure.
This hum after the QR. Like this.
Only good people can see that. I cannot.
Yes, you are.
Okay, Oyundari.
Okay. As I can see, it was initially started from sinus rhythm, and suddenly the premature atrial complex was revealed, and after again and again also P wave in here. Also, I think it's P wave, PQRS, PQRS, and also there is P QRS, inverted T wave, QRS, and P. Also, there is one P wave, buried QRS, and P wave, inverted T wave, and nerve QRS complex. Again, P wave, and QRS, P. And this is a fusion beat, fusion sinus rhythm, middle sinus rhythm with APC. Fusion beat, and suddenly start narrow QRS complex tachycardia.
Narrow QRS or
this one?
Wide QRS?
This one?
No. Next one. Fast one.
No, those are
250 beats per minute.
narrow.
Narrow. Look at V1. Is it
V1.
narrow? Are you sure?
I really like veteran. I really like veteran.
Okay,
Lightly.
so this is the exercise treadmill test recovery phase. So probably initial rhythm is more likely to be the sinus tachycardia and several beats of APC. All of a sudden slow down, and P wave morphology appear different. And then there is some other QRS morphology. Even during the slow heart rate, QRS morphology keep changing, and all of a sudden the tachycardia with almost 208 beats per minute tachycardia initiated. Okay. Coffee. Mechanism of tachycardia.
Say something new.
So looking at this beat in particular and matching it upwards, we see that it has an LBB-like morphology, and the coupling interval from here to here is shorter than the coupling interval from here to here. And so there's a possibility that this could be an Ashman kind of complex, but that one is typically a right bundle morphology. So I'm not too sure if this will be Ashman's. But after that, this I think goes on to begin this broad complex tachycardia, which is almost 300 beats per minute. And then over here, we have what I think is probably a, well, the QRS is shorter. So I'm not sure if this will be a fusion beat. I expect to be narrower. So, but this one doesn't look narrower. So I'm not sure if this is a fusion beat. So
then why the QRS morpho is different?
Okay, it's a fusion beat. It's a fusion beat. It's a very fast, but the intrinsicoid deflection is very sharp. So I think it is originating within the conduction system. I don't see retrograde P waves. I don't see clear AV dissociation either. So if I'm to give a differential, maybe over here, this is sinus rhythm, frequent PACs. Even here we have ectopic atrial rates, rhythms. This I think could be fascicular because of how the intrinsic deflection is sharp, it's broad, and it's very fast.
Fascicular VT?
Yes, possibly fascicular VT. Because of how the intrinsic deflection is very sharp. So I think it's definitely from the conduction system.
Yeah, I think it's difficult ECG. And I would like to listen to small Dr. Wang's thoughts.
Yeah, as previous all of our colleagues mentioned, I think it might be the middle one of the first, might be AT or front reduction, and then after PVC kind of morphology, then it changed to AT121 with the RBB morphology of overt conduction, but it is one possibility. I think.
So, why is the mechanics tachycardia?
To change of the refractory period and then conduction to 2:1. That's one possible mechanism.
You mean AT?
Might be, but that's one.
So the favors AT first.
AT or PSBT.
AT or PSBT. Then what kind of PSBT?
I'm not sure because it is treadmill test.
Seong, could you measure these RR interval and these RR interval? So Kofi mentioned about the different QRS morphology. It could be some extra bit overlap, make a fusion bit. So I would like to know this bit reset the tachycardia. Do you have a caliper? Same. So anyway, this rhythm did not reset the tachycardia. So what does it mean?
That it's not an accessory pathway.
I don't know if it's an accessory pathway or not, but anyway, this ventricular rhythm did not reset the tachycardia. Maybe. And I think it is unusual, and the PR interval is much longer than this guy and this guy. PR morphology also different, and PR interval different. And I guess it could be the PVC because PR is too short to be conducted. And what is this? If it is P wave, long PR and tachycardia induction, and no reset of tachycardia by different QRS morphology. So I favor the ABNRT, but could be wrong. Okay, Dr. Yu, finalize.
I've already mentioned what I wanted to say here. So, yeah, I mean, we don't know yet, but we can say that this guy did not affect the ongoing tachycardia cyclines and tachycardia malaise. So, but yeah, it can be possible if it is reciprocating tachycardia using bypass track, because there is almost the same interval. So I would like to say that number one diagnosis could be nodal reentry tachycardia, but we cannot exclude other kind of like AT or flutter so far. Okay.
So, Big Dr. Huang. So we list up the different diagnosis: vascular VT, atrial tachycardia, SVT, ABNRT, blah blah blah.
Okay. I guess we don't see that often exercise treadmill test ECG interpretation. And I thought that may be useful for fellows to, get used to as well, because this is one of the modality where we can make a diagnosis of cardiac arrhythmia, especially catecholamine sensitive tachycardia. So that's a clinical clue important here, because 39 seconds into the recovery, that means this man exercised stage 4 and then he's recovering, 39 seconds cooling down, suddenly have this change of rhythm. So obviously first 5 beat is the sinus rhythm, okay? And then 1, 2, 3, 4, 5 complex P is a fusion beat. Yeah, the sharp P. You can look at that in the lead 3, follow the P wave, sinus, suddenly change. Yeah, PP, yeah, that sharp guy. No, before, 1 beat before. Yeah, that's a fusion between 2 rhythm. So if you're thinking about the mechanism here, sinus is automatic rhythm, cannot be reentry. Okay, you can exist as reentry in the same chamber versus automatic tachycardia. It's got to be another ectopic rhythm to have a fusion. So this is ectopic APC, trigger tachycardia, faster rate now. And then keep going. If you look carefully, this P wave would become, this is marches. Actually here, patient had a premature beat, probably ventricular complex fusion beat here. And then just after that become 2-to-1 block. Okay, this atrial tachycardia 2-to-1 block. The clue is that if you look at the very beginning of a QRS of a 5 beat, have only heart rate 150, QRS beginning Q. Q wave disappear. Follow that. It's a small Q. No. Come back. No, back to the right. Come to the right. Yes, that QRS. No, you just passed. Small Q. Can you see that QRS complex? All right. Look at the next QRS. Slightly wider, almost no Q. Next QRS. Yeah, and then next QRS became even more positive, blunted. And then next QRS, that changed back. And then what happened? Next PRS is another PVC couplet, probably originating from the, right bundle origin. Then QRS become, left bundle, QRS become narrowish. And then full left bundle PVC. And then another PVC, the left bundle fusion, you can see very narrow QRS complex. Next, if you go to the V2, look at the V2. That very narrow, then much narrowish than the right bundle. So this is a fusion between left and right bundle. Therefore, evidence of this PVC is ventricular rhythm. Okay? That does what? tachycardia 2-to-1 block become 1-to-1 tachycardia. That's why going, so 300 beats per minute. So if you measure in rhythm strip, right side, fast tachycardia rate is almost twice faster than the 2-to-1 block. You can measure. So this is basically atrial tachycardia driving the ventricle. Patient had a PVC, also spontaneous PVC, which tended to cause peelback refractory. Remember, I asked you guys to read about that. This is the mechanism. Left ventricle PVC peeled back the AV node refractory became 1-to-1 conduction, atrial tachycardia. That's what most likely it is. Okay. So it is very interesting tracing, complex one. Again, remind you, you really need to understand peelback phenomena. Otherwise, you're going to miss a lot of differential diagnosis. Okay. This patient is, if you go slide down now, keep going, since you're not diagnosed. Okay, next slide. Let's go down. This is sustained tachycardia. But if you look at carefully, this tachycardia is not regular. They're slightly irregular, very fast or slightly irregular. Okay? And go to the next slide. Next one. Move a slide forward, please. Next slide. QRS become whitish. And then also become a little bit of change, especially V4, V5, V6. And then, no, go back to sinus tachycardia. Termination. Next slide. Yeah, this one. What happened here? That left ventricle PVC became almost multiple polymorphic VT pattern, which is terminal tachycardia, this patient. So if you look at this patient already have underlying incomplete right bundle branch blocks, is tachycardia, and then has a relatively undetermined axis, but it have a relatively deep S wave in the V4, V5, V6, even at the beginning. So that make a little bit of suspicious ECG. It's not a normal ECG. Okay, let's go. Next. Same in the recovery. And then look at that isolated PAC, second last bit. Do you see it? That PAC is actually in the top of a T wave. You can see that better in V5 and V4. T wave is a little bit shorter and sharper. See that? There's no downward reflection, it's gone. So this is most likely, if you look at it carefully, may not be the right atrial tachycardia. It looks like maybe left side tachycardia. Is already lateral precordial lead. Okay, go down. Keep going. Yes, now a patient in bigeminal PAC. Can you see that? No, just before that. You had some bigeminal PAC right here. So now you can determine where the P wave is coming from. 2-3 AVF is a positive. So it's not a inferior tachycardia, superior tachycardia. But if you look at the AVL, sharply negative, lead to slightly positive. Lead one slightly positive, lead the AVR is a negative, AVR is a negative. This is the left. Where you think is it coming from? Remember, you guys, we talked about before. P on T, where does the P on T usually come from? Pulmonary vein. There's a left side of pulmonary, is a pulmonary vein tachycardia. Okay? Keep going down. Yeah, then the recovery, same thing again. Keep going. Okay, and sinus rhythm. Okay, if you go to the history, that's actually very interesting because I think we need to discuss that briefly. It's important for teaching. Go down, next slide. Advanced slide, please. Next, okay. This is a 52-year-old guy presenting emergency with a syncope, okay? But he had one drink of alcohol. He tried to ride a subway and he suddenly experienced palpitation. He lost consciousness. So he brought to the emergency room and then we had a chance to see him. And he had a syncope workup already, 72-hour Holter show, normal sinus rhythm with a frequent PVC, mostly the left side. And treadmill test, what you saw today, that's a EKG. And then echo shows 52%. But the important thing here, what? Eccentric LVH diastolic dysfunction this guy has. Okay? Next slide. Go to the next slide. So we did an EP study on him. He had a multiple tachycardia induction, this guy. He got short RP, minimum pre-excitation questionable. He had a posterolateral AP, axillary pathway. Also, the dual nodal conduction, but a slow, fast AVNRT, much slower than tachycardia 300 beats per minute, even isoproterenol. And then he had isoproterenol 3-minute, 5-minute washout. He had a spontaneous PAC and left atrial paroxysmal ectopic atrial tachycardia from pulmonary vein. So it's not uncommon to see, these people have this multiple tachycardia syndrome, especially when you have unusual hypertrophic changes. We are not sure whether this man has a hypertrophic cardiomyopathy at this point, but certainly he has possibly hypertrophic cardiomyopathy related syndrome. So we are going to look at the MRI and gene testing. Then we have to bring him back to restudy him, ablate him, because we bumped the pathway, this guy. Okay. Go to the next slide, please. So as you know, hypertrophic cardiomyopathy can present a variety of manifestation, and that can be global hypertrophy, subtle, apical, all different form. 18 to 20% know that there's atrial fibrillation. They are high risk for embolic event. 8% of case they have a lopsided pathway or anterosubtle pathway, most commonly. In the multiple tachycardia HCM patient has a much higher risk of sudden death. Data so far no, but not that many cases published in a multiple tachycardia in a hypertrophic cardiomyopathy patient. So we do need to make a confirmed diagnosis, genetic testing on this man, get the MRI done, and then probably we need to bring back, study him, ablate him. Then at that point, we need to consider whether he needs ICD or not. Okay? That's I can tell you. Any question?
This ECG winner is small Dr. Wang.
Yes.
And I wonder, I think we need to implant ICD to this patient. But
I think so.
And
Yes.
also do you think anticoagulation is mandatory or not? Is this atrial tachycardia or fibrillation?
Atrial tachycardia. So I think that's debatable because of these people, as I said, there was a high risk of embolic event. As you know, I think I would go two approach. One, ablate the ectopic atrial tachycardia from pulmonary vein. Anyway, keep them, sort of on the anticoagulation, at least for prolonged period of time, at least 6 months, a year, while you're monitoring ICD, implanted monitoring activities. If he has no progression of a fibrillation, I think since you have a good monitoring system, ICD, I think I would just discontinue, manage his hypertrophic cardiomyopathy. But along the follow-up, any evidence that he might go into atrial fibrillation, I think it's prudent to give anticoagulation to this man. Okay? That would be, I don't think there's a right answer or wrong answer here. I just need to consider about that, a high-risk embolic event. Okay? Any other question?
Can I see the first ECG? Okay.
Yes, please.
So in B1, 1, 2, third bit,
Yeah,
looks narrow currents.
that's correct.
Yeah.
Yes.
So, and at the baseline rhythm is bundle branch block pattern, the wide QRS. If the intervening bit shows the narrow QRS, it is PVC induced, the fusion bit.
Which one?
Narrow QRS.
That's a PVC induced. Yes, correct.
Yes.
Left side PVC origin.
Yeah, I think the fellows, if fellows know that, it's useful to interpret ECG.
Right.
Baseline wide QRS rhythm, but if there's intervening the narrow QRS, it is fusion bit with PVC. Okay. Very nice case.
Okay. So keep looking. Exercise treatment test ECG is not same as a 12-lead ECG. It's a little more challenging. Okay. So you needed to have so there's one more thing I want to point out. If you look at the V3, there's an unusual sharp negative like potential from a QRS complex. Point of V3 after the PVC. Okay. Next bit, you see sharp potential. Go point out QRS just before the QRS. That sharp potential. Yeah, that guy. Follow the next one. Okay. Yeah, that one. Next one. Now closer to QRS, morphology changes. Can you see that? This is evidence this is not a reentry. This is ectopic atrial tachycardia driving V, not the A. Okay, V driving A, opposite. So that notching is actually P. Okay? It's very difficult to appreciate that. You never see right bundle like that, especially incomplete right bundle. That has to be ventricular refractory period, remember? So no other activity can happen, yet this patient has that variable small notching potential. So look carefully, then you will see. That thing is marching off slowly, okay? Okay, guys, good exercise. You can, Dr. Jung, you can put it on my next slide that I gave you. I'll just work through with you, okay? You can load, just give a minute here. Okay, this is a case I did with someone in Korea a while ago. But I was a little bit curious about this case because I haven't seen this for a long time. It's not common. So I just want to share with you what our thoughts are. But we don't have a really true histologic or either clinical manifestations fully comprehensible tachycardia. So this is an 18-year female patient who referred to us 2026. But when she started the first tachycardia, 2020, so she was 11 years old. Okay, next slide. Go advanced. Yeah, there we go. If you look at this is when she was 11, tachycardia rather fast, and the narrow QRS complex tachycardia, obviously. And then you can see almost distinctive notching in V1 in T wave. You see that W sign there? Yeah, that guy. Next bit you can see even better. So clearly there's a P wave there. But the P wave is a negative. So you start thinking, you know, if this is a P wave, look at the 2-3 AVF. P has to be positive, right? You can see it. It's not a negative, it's a positive. Yeah, and then all especially the 2, you can see better. So you start wondering, this is an anterior originating tachycardia and the inferior axis, relatively normal QRS complex in young lady. But if you're thinking about differential diagnosis at 11 years old, this cannot be AVNRT. It's got to be something unusual. So typical AVNRT, epidemiologically, we start seeing teenager time, 15, 16, so on. Not 11 years old this fast, okay? Keep that in mind. Okay, next slide. So they did EP study and the baseline conduction interval normal, and there's no pre-excitation, signs of activation is normal. Okay, next slide. They induced tachycardia isopreteral of the birth spacing. And they noticed, top slide section there, the induced tachycardia after AH jump. Okay? But my question to you, can you conclude AH jump during the Wenkiba? You can see first 3 bit of tracing the Wenkiba. Do you see it? Ventricular A pacing suggests blocked, first one. Second one conduct, that's blocked. Second conduct, the short PR. Third one conduct. Fourth one, very long PR, haven't blocked yet. So progressive prolongation, maybe the Wenkiba induced tachycardia. Yeah, it is probably, you can think about it, particularly when the Wenkiba cycle length is progressive in atypical form, when you use a fast and slow type of. So you could argue that. But I want you to notice one thing though. If you look at the septal A, last bit, okay? If you're thinking that's A, I think HB, septal A is wavefront, and then retrograde septum A is where it is, right at the His 3-4. That's it has to be retrograde A. So if you look at the His bundle pacing, second complex, there is right at the QRS, there is a distinctive AHB. So septal activation is early as we interpret this 12 ECG, okay? But they interpret this as something else. Okay, next slide. Okay, advanced slide, please. Okay. So then this is basically same clinical tachycardia that you saw in 12-lead ECG. Okay. Okay. Next slide, please. This is their conclusion was this was atypical AVNRT, fast slow form. My question to you, is this consistent with a fast flow AVNRT? Yes or no? What is missing here? Your A should be right front of his bundle, but your A is way off, way front than CS. So sequence is wrong here, first place. Okay? Because long RP tachycardia, if you're going to the slow to the fast, I should see after the distal CS right front of his bundle potential, I should expect some atrial activation, not in the right after the QRS complex. So if that is the case, then we need to discuss what are the differential diagnosis units and think about this one here. Okay. And second thing that you're looking for is that the even though atrial activation, his bundle is not that clear at this point. You see proximal history for atrial potential is what? Like a W sign. Can you see that? Very wide. Take a look at it. This is not typically what you see in the AVNRT. That W sign means impulse is coming almost perpendicular to your catheter. Okay? All right, let's go. So keep moving. And then the entrainment pacing is consistent, right? What is the response you get? BAV response, right? Am I right? VAV, last pace, VA, and then went down to the V. But a PPI minus tachycardia cycle at 138 milliseconds. So it's not consistent with the pathway. Okay, but you have not excluded the possibility of AVNRT, neither the ectopic atrial tachycardia, any of those. Okay? Go to the next slide, please. So they start mapping. They thought that this is a fast, slow AVNRT. So they mapped the anteroseptal region with the ablation catheter. And then you can see, if you look at that carefully, your anteroseptum is clearly earlier than your proximal CS, and then later than the his A. So it is activated sequence, if you will, coming from right distal his, come to the ablation and CS, and then going back up to the left atrium. So this activation sequence is anterior to the posterior, basically what you're telling us. And question is, can we have an AVNRT like that? Very unlikely, okay? So look at the activation sequence, think as a vector. I modified the slide for you guys, the teaching, so I'll give you later all this point. I wrote all that down. Okay, next slide. Keep going. Okay, so they moved the catheter to the posterior septum, mapping slow pathway, and then basically close the proximal CS. Next slide, please. They ablated the junction rhythm. Okay, so they thought there was enough successful ablation. I think that's the end of the study. I do not know whether they did post-ablation testing or not at this point, and there's no documentation of it. Okay, go to the next, please. This ablation site they did fluoroscopically presented. So they ablated a few points, I think, not a single point. Okay, next. And 2021, I think she came back with a tachycardia. That's why they had a recording of 12-lead ECG. It's a normal sinus rhythm. Really not much a significant different abnormal thing I found. Okay, next slide, please. They did a parahisian pacing to ruling out the, make sure there's no auxiliary pathway, which is actually the sequence is the same. Okay, next. And the RB pacing, if you look at the SONS2, they pointed out there, but if you look carefully, earliest activation site is what? his. Okay. If you look at the his channel 1, 2, next bit, come back to the right. Come to the right, one more. Yeah, there you go. There's his potential right there. Retrograde his, and the local V, and A after that. So there's a 3 complex that you can see. That's a retrograde A right there, which is earlier than anything else. Okay? There is some sharp distinctive potential in the CS proximal. Can you see it? If you go down, CS 910, yeah, that guy. So they maybe that thought that was a slope at the potential. I think they decided to, thinking this is another AVNRT recurrence. Go down, please. Next slide. So they basically try to map the further, again, the tachycardia circuit, slow pathway. They find the ablation potential there. Okay. Go down. Next slide. Yeah. So they measure, but then again, during this tachycardia, you can look at his distal clearly earlier than proximal A, and then polarity reversed a little bit. And then you have a CS activation time is way late. So question is that this impulse coming between his distal and proximal, very unlikely this is a slow AVNRT activation pattern. I think they did not appreciate that during the study. Okay. Okay, next, let's go take a look at that next slide, please. So they ablated, I think, VA block adenosine sensitivity. They tested and make sure that this is not an AVRT. So clearly VA block, so there is no pathway according to them. Okay, next slide, please. So they decided to ablate that potential and obviously the junctional rhythm. Again, nice response. So the slow pathway modification. And then I think they ended up again. Okay, next slide, please. And that's almost similar size, but a little bit higher this time, ablation, okay, than the prior ablation. Okay, next slide. So she came back in 2026, same tachycardia, the emergency room. So they wondering what to do. So we went, share the case together. Okay, next slide, please. Advanced slide. Okay, there we go. And that time, patient sinus bradycardia a little bit more T-wave inversions, but nothing really significant. Also, EKG is not very stable baseline. It is during the EP study. Okay, next, please. Go ahead, advance the slide for me. So baseline recordings. Okay, go back there. Now we try to get as much as possible the best EGM of his bundle. So you can see now, same activation sequence, nice his bundle potential proximal and distal. And so baseline conduction measurements are normal. Okay, next slide. And then if you look at the extra stimulus and the VA AV node conduction, there's no dual AV node physiology because she ablated twice already. There's no slow pathway anywhere. Okay. All right, next slide, please. And same thing, we give isopreternal burst spacing HRA 220 to mic infusion, induced tachycardia. Question is, where do you think the tachycardia initiated? That would be an interesting question. First bit did not capture, first A, okay? If you look at the pacing spike, yeah, there's no A, okay? Second capture, second bit, you follow? Yeah, that capture A, okay? Then look at the pure morphology, a little bit different. And they especially look at pay attention to the CS EGM. So changes slightly, first bit to the second bit. They change the previous one, next one. Yeah, that bit, and then so on. So I think tachycardia was induced by then already here, intermittent fusion going on. And then rebound morphology changes the QRS morphology, then finally sustained tachycardia. Okay? So it's not uncommon when you guys burst pacing atrium or CS matter, your tachycardia will initiate during the tachycardia. So that is a very important mechanistic diagnosis because to induce tachycardia, this patient started almost like immediately, without any jump or anything like that. So that was a further confirmation this is not a AVNRT. Okay, so look carefully when you're burst pacing during the tachycardia as well as after the pacing. Okay, next slide, please. So this is a sustained clinical tachycardia, same as we saw before. Really nothing changed. Keep going. Next slide. Okay, there we go. This is interesting tracing. Because we got a good His bundle potential, and we saw during the tachycardia this very early high frequency spike, proximal distal His bundle marked in the reddish kind of color, the orange color arrow. Can you see that? And then you have also His bundle in the black. I want you to notice that maybe perhaps, especially His distal early potential, polarity is different than His proximal 3-4. That's a positive. His potential is negative. His coming back, yeah, channel to the, yeah, there we go. So you wonder, this tachycardia activating opposite direction of the His bundle wavefront. So it can be AVNRT. Second, some of them have more than one high frequency spike. So initially I thought this was noisy. But if you go back carefully and during the second episode they did, also they have a similar spike. I forgot to point that out for you, but you can appreciate that when you go back, look at the slide again. So definitely earliest activation is in the His distal to proximal, which is the opposite direction of His bundle, wavefront. Okay? Next slide, please. And then tachycardia spontaneously terminate, they initiates. So you can see terminate by P, it's non-sustained acceleration pattern, and then also terminate, and sinus, and then also acceleration initiation. So spontaneous going on and off. So this is make a perfect diagnosis of ectopic atrial tachycardia. Okay. All right. Next slide. So we did map the His bundle area, the earliest, obviously. Go to the slide, please. Next slide. And we tried to use a grid, but then right septum, nothing was earlier than His. But remember, we have to be earlier than His A, that small noisy potential. We need to be that early. So we use a grid catheter. We mapped the right anterior septum, nothing early of the all far field signal, very late. Next slide, please. And then we went to the NCC because closer His bundle. That's typically what we do, non-coronary cuspid. And that site also mapping was initially not that great. Even ablation mapping was not earlier than His. So it's the same time almost. Okay, His A, not the diaphragm potential. Okay, next slide, take a look. So we used to the NCC posterior left posterior aspect of NCC more toward the back of aorta. And you can see earlier signal than His, but also sharper potential than what we saw in the half of the right side of the NCC. Now you have to remember two things. NCC, they basically cover both atria. Half the right side is the right atrium, half the posterior side, the left atrium. Okay, so when you rotate a catheter more toward the left coronary artery cuspid and the NCC junction toward that posterolateral wall, left side, you got to start thinking maybe this is the left side atrial tachycardia. Okay, even though you move very slightly catheter, it can make a huge difference. So it needs to be mapped carefully, that area. Okay, next slide, please. So we tried to find this area with the ablation catheter. Ablation catheter indeed, not early, but is not much as His bundle. We looked around much as possible. We did not find any good potential there. So next slide, please. And then we tried to ablate from there, far field target, but nothing really happened. Nothing good, exciting. So we stopped that. Okay. All right. Next slide, please. So we did the transseptal and we went to the left anterior paraseptal region. You can see now your A start becoming earlier as His bundle, particularly in the last second bit there, you can see that sharper potential, a local A, his coming down, grid, D2, D3, D2, D3. Yeah, that big signal. No, that's a caliber of a distal CS. Big A, come to the left. Yeah. That's A, okay? You can see C1, C2 has a sharper R. Can you see that? That's the earliest paraseptal area we found initially, okay? Slightly earlier than his, but not much. Also, it looks promising though, okay? All right, go to next, please. So we mapped that area. I left to grid into the aortic valve area, non-NCC area, the highest potential, and then I moved the ablation into the transeptal. We moved the mapping around. We found a small sharp potential, also a little bit hard to see in ablation, and we could see better, and almost like earlier than he said. So if you go to the last bit of ablation, maybe you can see better. Distal, ablation distal. Last bit, just one before. Keep coming. Oblate. Yeah, you passed. It's small potential. Yeah, that guy, small potential, just hump. No, little bit left, millimeter left. Yeah, that guy. If you look carefully, every single bit has that noisy. Come and goes. Because the difference between grid and ablation distal electrode size, you're not going to see sharp potential as. So this is what is approximately target area. So we ablate from the left paraseptal. Next slide. And terminate tachycardia. But took for a while, about 10, 11 seconds. But then when we paste again, patient was reinducible. Okay. Go to the next slide. So then we mapped carefully again, the ablation, we found that sharp potential better, a little bit higher, more posterior. That sharp potential in the red arrow. And you can see propagation, that sharp potential, the distal to proximal. So your vector was appropriate. We are pointing the right direction. Next slide. We ablate the high power because the far field signal, 40 watts in 3 seconds and 3.5 seconds, and tachycardia terminated. After that, patient has no longer inducible. Obviously, concern here this area is that whether you're damaging AV node or not, so you need to watch, make sure the junction rhythm, so on. But danger of ablating tachycardia is that you may not appreciate junction rhythm. But I'll tell you a little bit later, the junction rhythm from this region usually is not that high risk of heart block compared to the right side. Okay, next slide. So this is basically post-ablation, AV node conduction check, everything was normal. So we wrap up the case here. Go to the next slide. Okay, so this is a 3D mapping of grid put together. And you can see the front grid, gray area, the multiple dot of the aorta. The gray color back is a right septum, right? And then red is a left transeptal. And you can see the green dot and the white, that's his bundle right side. And then aortic green dots, the aortic far field his bundle tagged, okay? And then left side, there was his bundle and the pink dot. On the right side of the picture, you can see left side, the far field his, okay? A little bit lower. Tachycardia focus a little bit higher. And if you go to the next slide, we ablate first on the right side of the map. You can take a look at it, two red dot there, okay? First one ablate a little bit lower, higher one than last ablation, successful ablation, up, higher up. That's the first ablation, the second ablation, yeah. That was a successful site. So this is clearly a little bit higher than the, his bundle that we usually see. Okay, next slide. So you're putting together in different view, you can see, and the left his, right his, and so on, ablation, and then all that. So you can basically create a good 3D map when you do this area. Make sure that you target his bundle right and left, and then make sure you're not close enough to cause a, his bundle damage or heart block. Okay, that is basically mapping technique. Next slide, please. There is a paper recently being published since 2015 or so. Bob Anderson lab, especially Dutch group, Dr. Wellen's lab, they're much interested on this retroaortic AV node model. if you look at the embryologically in the left side, this is a AV canal formation embryologic drawing. Basically, tracheotomy mitral valve. There's yellowish brown, orangey colors are primitive atrial tissue that have a capability of a automaticity. They connect in 43 and so on. They can become sort of like a slopathy structure. You notice that your retroaortic area that basically wrap around the aorta. Now, the red area colored is retroaortic node between the mitral and tracheotomy valve, which closes his bundle. And then right side is histologic demonstration of retroaortic node, and in the picture, it's a corresponding area. Go to the next slide. So if you look at our case, and the ablation is basically essentially an area that the target, they're pointing to you, and between the right and left atrium and the above the bundle and so on, okay? So it is important that to remind you. Now, this is very common, such a fragmented low frequency signal cases is not common, very rare. But take a look at the data. Go to the next slide, please. Oh, goodness, okay. I have to tell the story then. That did not include. I send you two papers, okay? I'm going to send you email to you. One is a paper written by the Wellens group, 2018. Prior to that, 2016, Japanese group published the superior slow pathway in patient with a fast slow AV NRT ablation of 8 case. That created a lot of skepticism, if you will, believing that how can fast slow pathway ablation is done and slow pathway is superior. Those patients also notoriously be ablated traditional slow pathway area. And their argument is that these patients have a slow pathway abnormally located and is superior to the AV node. But if you look at the ablation site in that paper, circulation paper, they ablated 4 patients from coronary cuspid, NCC, and 4 rest of them, 4 to 5 million just above the his bundle. That reminded me a long time ago, very first time before we do slow pathway ablation, Freddie Moradi used to do fast pathway ablation, slow for AV NRT, just historic point. So very popular between 1990 and 91. Problem with that technique is that often we will result to first AV block because you injured this fast pathway, or sometimes high incidence of heart block up to 6%. So we abandoned that technique. And the Japanese guys are just claiming that this is an unusual type of AV NRT. This patient had a post-superior slow pathway. Obviously, since 1991 to 2016, they have a lot of technological improvement, CARTO system, 3D mapping, so on. Maybe they could ablate target a little bit better, that area. But then behavior of patient is completely unusual, especially when you're ablating non-coronary cuspid AV NRT. And the Wellens paper published at ESC, Europace, I want to look at that. They have a collection of 34 patients, female, mean age 54. They did all of them ablate from NCC. And they're interestingly, they're all of them adenosine sensitive. That's another distinctive feature. And then they did look at their potential. They have a potential exactly the same as I shown you today. His bundle distal has a fragment potential plus his bundle potential in patients who have ectopic atrial tachycardia. So they are arguing that maybe that fragment signal originating from retroaortic AV node could be where the mechanism micro reentry versus ectopic atrial tachycardia is not known. But it is exists such tachycardia, and I think I am more favorable for the Wellens data than Japanese Kaneko data. Even in his paper, Wellen argue about that Japanese data is really right or wrong. He thinks it's wrong. Okay? So I want to read the paper, take a look at it. So next time when you have anterosubthalamic tachycardia, adenosine sensitive, think about retroaortic node. Okay? It's not common, but we see time to time. I just brought this case because of such a rare case, was thought very interesting to share with you guys. That's it. Thank you so much, guys. Dr. Jung, I will send you reference right now, email. Okay? 2 paper. Any question, please?
이 환자가 ABNRT였던 건가요?
No, wrong. First place misdiagnosed. Sorry to tell you that. And
아니,
she had
양상은 ectopic atrial tachycardia 같이 마지막에 보여주셨는데 지금
at the beginning.
retrograde aortic node라고 그러시니까 지금 좀 진단이 먼저 헷갈려가지고요.
Oh, because the retrograde aortic node usually not involved in the AVNRT. They present like an ectopic atrial tachycardia. So if you review the Wellens paper, you make that very clear. Okay?
아니, 그러니까 지금 보여주신 이 케이스는 진단이 뭔가요?
Ectopic atrial tachycardia from retrograde node. That's what it is. That's why you have that distinctive anteroseptal his bundle axis, atrial tachycardia. Anterior B1 is negative, positive in 2-3 AVF. And then you have that distinctive his bundle fragmented ECG way earlier than local A. And then his A followed by CS and so on. Okay? It's behaving like a middle and long RP tachycardia. Something like that.
그럼 그냥 일반적인 그 NCC나 리토
Yes.
에어타 근처에서 나오는 ectopic atrial tachycardia하고 이런
Yes.
retro aortic node에서 나오는 ectopic atrial tachycardia하고 뭐 EP finding으로 감별이 가능한가요?
Adenosine sensitivity, 1. Number 2, much younger age. Kaneko patient over 70 years old. These patients are less than 50, most of them. So that's what I said. This is a young lady, a young female. We did a study, 18 years old. So it's a very unusual presentation, but such disease exists. So, but I think a more important point I want to make, fellows, please, during the EP study, look at the his bundle EGM during the tachycardia and also induction carefully. Not just his bundle V. Sometimes you will find this unusual high frequency fragmented potential that will be diagnostic, those cases. I only seen 2 of this. This is the 3rd case I've seen. And I always curious about it. What would be, why is there such differences? But then my case was, this is 18 years old we ablated, but most of them are 30s. So I thought that may be something that we need to differentiate further. So if you see next time you suspect anteroseptal atrial tachycardia, give adenosine, see what happened. Terminal not. Okay? Old age, not NCC, ectopic atrial tachycardia, adenosine doesn't do anything in our experience. It's just heart block and PP keep going. Okay? Did I answer your question, Dr. O? Dr. Pao? Your question or no?
But as far as I know, some of septal atrial tachycardia also respond to adenosine. So
yes,
yeah, anatomically it is close to retro aortic node, but we don't have direct proof this case is coming from the retrograde aortic node.
Yes, we don't. That's why they said that the Wellens is dying to prove that's what it is. And then I think interesting is that first of all, many of us don't know even retro aortic node such thing exists in anatomy, right? A lot of people here first time said, wow, what is this? So the reason I became interested on this because when we wrote a node ventricular axillary pathway case, remember that left side NCC case? Actually, Jose Quintana raised that question. This is not whether connection into the retrograde node rather than a slow pathway. So it was a little bit of a sort of a discussion, but I told the same thing. There's no proof that the human case of histologically, pathologically shown live patient anyway, not that patient, had retrograde node. But his argument that they see quite frequently retrograde node presence in many cadaver heart. So connection between 2 and real world, lucky. But then would it be reasonable to assume that this is a focus? And then the argument they have that such a high frequency signal, Wellens paper, he described it. And then all of them adenosine sensitive, younger age. Septal tachycardia, not all of them uniformly sensitive to the adenosine, as far as I know. Only maybe 1/3 of patient adenosine sensitivity. So whether
sorry. Another question is during the first and second procedures,
Yes.
The previous operators misdiagnosed as atypical form AV node reentry. But I wondered during the previous EP study, did they see the typical induction pattern of AV node reentry by programmed stimulation or not? You showed one induction episode, but it was the Winky bar pattern and not the one-to-one stimulation, right?
No. They as far as the data they sent it to me, there was no evidence of typical maneuvering we like to do S1, S2 and baseline. And also, unfortunately, they haven't not sent me any data post-ablation testing. I think that would be more important. But they have not sent me any data. I don't know whether they did or not post-ablation, re-stimulation, reinduction. Okay? That I cannot tell you because I just got the second-hand cases. So I'm sure they did. I think this is not a just regular prestigious institution in Korea. So anyway, that's not the point. Point is the teaching. So I think important to observe entire induction method plus post-ablation evaluation to complete the procedure. Okay. So I think if you ask me what my guess is, if they done reinduction, I bet the patient was reinducible that time. Especially during the second procedure, that sharp potential. One of the slides shows, same EGM. I was curious about it because why they did not see it. Maybe they did not have time to, see that. To now, spend too much time looking at the EGM. So this emphasize again, careful looking at you guys to study, not hurry to the procedure. You need to enjoy, fellows, EGM. Try to make a habit of it. So you can see, and will be much better. If you look at slide 15, the second procedure, if you can pull back slide 15 of your second procedure, keep going. Yes, 15. No, I think next one. Yeah. No, that's P-pacing. After that one. Go one slide forward. There. If you look at his A, there's a small hump. Two of them. Like say the second, third, every bit has it. Take a look. V, his distal. Go to his distal. Okay. And then look at the VA before the his bundle. Yeah, there's a two hump. Slowly come to the left. That one. You see that? No. Small hump. Yeah, keep coming to the right. Keep coming to the right. Keep coming. Keep coming. Keep coming. Coming. Right there. 2 bit there. You see? Small spike. Distal. It's distal. You see better? You can see clearly that's positive. His is a negative following his. That's the blue arrow in there. You see his is way back at distal. Big his. That one, positive. Go to the right, and then you see his negative. So this wavefront clearly opposite of his bundle. Activation, propagation. So I think have to assume that this is sort of a ectopic tachycardia with a lot of activity or micro reentry. I don't know what is the mechanism, but certainly very distinctive. Next time, yes.
What is the fractionate potential in the HIS 3-4 followed by local V?
Which one?
Yeah, that arrow.
So we argue that this was a noise or not. Okay, the proximal.
I think it's true.
Yeah, it's hard to know, but the frequency of the proximal appears to be more 60 cycle noisy when I measured it. Okay, but in the distal, EGM is much cleaner. I was suspecting. I wasn't sure. But when I did the third time, that potential is still there. I said, wow, this is a real thing. It's not an artifact. Especially you can see in a bit before, the quality of that sharp potential is much better. Yeah, so please look for his EGM carefully, guys. It tell you a lot of story. Okay?
So if the HIS 3-4, his proximal local A is earlier than distal local A, the next bit.
No.
local. 이거 히스고 애쓴다 했어. 더 앞에 fractionation.
Yeah, fractionation.
Yeah,
No,
yeah.
I'm not
If
sure
it-
that's A. That's a polarity reversed. You see that positive. This is a positive, this is a negative, Dr. Bach.
But it could be the reflex the atopic atrial tachycardia earliest activation.
Could
Don't
be.
you think so?
And
Yeah.
it's yeah.
So if the his A is proximal is earlier than distal, it reflects the potentially more likely to be atopic atrial tachycardia coming from the retroaortic aortic area than the AV node reentry. Am I right? Or,
Correct. Yes.
Yeah.
Because first of all, your AVNRT, when the septal age is that early, can be AVNRT. Look at the difference between your timing from that to the CS. Is more than 80 milliseconds long. How can you have a AVNRT that's such a separation of activation? And then also wavefront is completely wrong because a distal is positive, proximal is negative. So somewhere between two breaking off. So that is not consistent with the AVNRT. So I think when you look at the EGMs, really you can recognize, oh, this is not a activated tachycardia. Then second thing that I want you to notice, this is tracing. Look at the HRA. Your HRA is earlier than CS. Can you see that?
Yes.
Yeah, right.
Yes.
How can be AVNRT? It's not possible. So there's a lot of many tracing suggests that this is not AVNRT. They should have noticed in second procedure, especially redo AVNRT cases. This is very unusual. Okay. I am not trying to criticize anyone, but I'm just trying to show you guys what presentation of tachycardia can be. Bottom line answer going to be EGM. So take a look at the EGM, okay? Then you will find the answer, especially when you're confused, you're getting troubled. It's not your mentor, it's not your teacher, it's your EGM. That always has been a lesson to me over the years. So especially many of you are going to be practicing solo when you practice, when you graduated. Sometimes can be scary, can be trouble. If you practice now looking at the EGM, you'll be much better shape. Okay, I can tell you that.
I would like to say also the strict the EP criteria of diagnosis before burn.
Right, absolutely. I mean, if you do every time same way, same methodology, you will likely you get in less trouble. If you try to invent something new, then you get confused and get in trouble. Okay.
Okay.
You know, the argument is that this could be micro reentry. If you look at the His bundle distal, that sharp potential. If it's a good eye, maybe you can tell me I'm imagining. First, a sharp potential positive. Second potential negative. That small potential. Almost I envision like a turning around, almost micro reentry. But I can't really, say anything else because I wasn't there. But that's what I saw initially. I said, "Wow,
that could be."
Yeah, yeah. So I think it
Hypothesis.
is. Yeah. Sometimes a lot of people tells me I'm imagining too many things. Yes, I do, because I try to make an effort to see new EGM if I can. But it is a fascinating word. Okay, gentlemen, I appreciate your time. Sorry, a little over time. Sorry about the technical issue.
Please ask a question.
Oh yeah, please do. Anything.
You understood everything. Copy.
Oh, wonderful. I mean, you guys present the everyday SBT is something different, and we have to bring something different too. So I thought that might be useful for you. Okay.
Okay, I appreciate Dr. Huang. Very interesting cases and educational, very important messages.
Yeah. All right.
Have a wonderful weekend, and thank you.
You guys too. Okay. Thank you so much. Bye-bye.
감사합니다. 네.
Yes. I'll send you. Okay. I'll send you email right now.